Those copies. This afternoon's first speaker is Dr. Ronald Billings, who had earned both his dental degree and his master's in science at the University of Indiana. Along with Dr. Kumar, he is an epidemiologist, which is the type of talk we need. In other words, there are many things that are counterintuitive. We think we know the answer. We even tell our patients that's the answer, but when you actually collect the data, it isn't the answer. A very common an incident I've just heard of was that in vitro fertilization in women under 35, you think that if you put in one egg or 3 eggs that the number of pregnancies would go up. The number of women that would get pregnant would go up. Actually, with 1 egg, 48% of the women become pregnant. With 3 eggs, 45% of the women get pregnant. So you think you know the answer until you look at the data. Dr. Billings' topic today is severe early childhood caries and the burden and cost involved. Dr. Billings is the Director Emeritus, a very respected director at the Eastman Dental Dispenser. He's a professor in the Division of Community Dentistry and Oral Disease Prevention. He's a mentor to a number of younger dentists and graduate students. As a matter of fact, both of the speakers that follow him, I think, would be included in that group. He has numerous articles and lectures on the subject of dental caries in the young and old. I think that's the next one. So, please, Dr. Billings.
Thank you, Tom.
Thank you.
Thank you very much. I assume Nick turned on my microphone. You can hear me okay? First of all, I need to thank Tom for organizing this event, and I tried mightily, as he will probably be happy to tell you, to weasel out of this because I thought there are so many other exceptionally well-qualified people to speak on this particular topic. I felt even stronger about that after I got here and listened to Jay's presentation and to Steve's presentation. So this morning when I was putting my shirt on, I was muttering to myself, I'm usually very optimistic, and my nickname is the Eternal Optimist, but I'm buttoning my collar and I said, you know, it'd just be my luck, you know, I'm running just a little bit behind here. One of these stupid collar buttons will break. They always do. And sure enough, the stupid thing broke. And I said, you know, that's a bad omen. So I thought, what is going to happen here? Well, I'll tell you what happened. I have to follow Jay and Steve and lunch. So for those of you who are sitting on this side of the dividing aisle, there's no quiz because I'll come to you. But for everyone in the back, there's an essay test at the end of this. So pay attention. And if you fall asleep, I'm coming up there. So in any event, my presentation is going to slip right in the seams between Jay's presentation and Steve's presentation. I'm going to focus on the only part of really public health that I know even a little bit about, and that's dental caries. I have to tell you, when I graduated from dental school and did my public health work, I thought to myself, you know, trying to prevent caries in my patients, and particularly preventing recurrent caries. This was nearly 40 years ago. And I said, yeah, that's about right, about almost 40 years ago, 69. So I said, you know, if I just knew a little bit more about this stupid disease. You don't really learn about caries in school, as anyone here, hygienist or dentist, will attest. You really don't learn really until you're out there and one sees it up close and personal. And I said, you know, if I go back to school and if I just learn a little bit more about this disease, I'll be able to really do well for society and for my patients. And so I did. I went back to school and I got a master's degree in dental science from the then Preventive Dentistry Research Institute at Indiana University. And then I came out of that experience saying, well, you know, I know a lot, but I still don't know as much as I would like to know. And so at that time, the NIH had just introduced the Cardiology program, and so I was accepted into the Cardiology program at the University of Minnesota. And so then I finally started, you know, my real career after that. And I have always focused on that burning question, if we just knew a little bit more. And several years ago, colleagues, we developed actually a caries risk assessment protocol. We could positively, without fail, identify children who are going to have caries onset within the next 6 months. It was great. But the problem was it only costs about $150 per kid to do this. So who the heck is going to pay for this? I can tell you it's not the government, it's not the insurance companies, and it's for sure not patients. So we sort of went back to the drawing board with regard to risk of caries onset. And we're still there. There are a number of protocols out there, but the one I want to talk about is downstream from both Jay's presentation and from Steve's presentation, because Jay's talking about things a little bit more globally than I'm going to talk about it. I'm going to focus in on the aspects of one particular oral disease that is just wreaking havoc in certain components of our society. And Steve was right on the mark in terms of providing oral health care for pregnant women, because that's probably where the action is in terms of preventing what we now call early childhood caries. The pediatric dentists have batted around this phrase for some time before settling on ECC, early childhood caries, and its more severe form, severe early childhood caries, which I will describe in a moment. I'm not going to dwell on my preamble because Jay covered this very, very nicely. This is the most chronic childhood disease. Caries is increasing in the primary dentition in very young children, and we can attest to that in our own surveillance in Monroe County, and that this is the most prevalent unmet health care need. But we have focused on early childhood caries, which the pediatric dentist finally determined what they were going to call this. It's been called baby bottle caries, nursing caries, and other names as well. It's known by other names. But now it's recognized as early childhood caries, and they have developed a very specific guidelines, and it's not a guideline. They have developed specific criteria for what is and what is not early childhood caries and what is and is not severe early childhood caries, because they're fairly different from one another. But early childhood caries is one or more decayed, missing due to caries, or filled tooth surface, single surface, in any primary tooth in a child approximately just less than 6 years of age. So that's the definition for early childhood caries. And then we come to severe early childhood caries, which is a more acute form of this disease. And it's any sign of smooth surface caries in children younger than 3 years of age. And this is fairly critical because in our surveillance studies in Rochester, we have identified in the preschool population that attends child care centers, approximately 40% of the children attending these daycare centers who are between the ages of 1 and 3, 40% already have this severe form of early childhood caries. Worse than that, 95% of these children have not seen a dentist. And we'll talk about that as we talk more about the burden. And then the definition of severe early childhood caries gets a little bit more complex than it probably really needs to be. This probably represents the more pedantic or bureaucratic approach to it. But then we get into this business of one or more decayed or missing anterior teeth, ages 3 through 5, or greater than a decayed missing and filled surface count, greater than 4, greater than 5, and so on. But I think the area that we're going to focus on here, and which I think is the most significant, is this group right here, the children that are 3 years of age or younger. And as you'll see as we go through this, the reason why this is the group to focus on is they have the highest burden and the highest cost and the greatest mortality morbidity risk, because virtually all of these children have to be treated in an operating room under a general anesthesia because they have not reached an age where they can be cooperative, number one, and number two, their disease typically by the time they are referred for care to the pediatric dentist, the disease is too far advanced to treat locally in a chair. So, as you can well imagine, anytime you put a small kid under general anesthetic in an operating room, the risk for mortality and morbidity just automatically goes up. So there's always concern on that front. And I could probably stop right here after my next sentence, but you'll have to sit and listen anyway. Approximately 50% of these kids who are treated in an operating room relapse with new disease within 6 months after treatment. So it's horribly depressing for the pediatric community, both pediatricians and pediatric dentists, to put a child through this, the parents through this, caregivers through this, only to see that the treatment outcomes are unacceptable. And so work is now being pushed. Our very narrow niche now is within the area of these 1 to 3 year old children, is to try to the best of our ability to develop preventive protocols to reduce the level of prevalence of recurrence of new caries in these post-treatment severe ECC children. So this is what it looks like, and you can see the demineralized enamel on the labial surfaces of the centrals and some actual demineralization on the lateral here. And then we see the end as the disease progresses. This is severe. This is a kid 3 years of age. And then this is a more advanced case and a still more advanced case. Unfortunately, these don't reproduce real well in these slides. But I think they certainly give you the picture of what's happening here. So this is what we are up against. So I have structured my presentation called The Burden and the Cost, so that I can sort of give you some sense of who shares the burden, both from a societal perspective as well as from a family perspective. Who is burdened by this disease process? Who bears the greatest burden? Clearly, the community health providers certainly have a tremendous burden here, simply because we are so undermanned. And there are, just as Tom has indicated, that there are the manpower issue in this part of New York is critical. It's just as critical in Rochester, in particular in the community health centers that are the safety net for the low-income population. And this is where the disease is. We'll get to that as we go along. But the 90%, forget this 75-25, the burden of severe early childhood caries, and early childhood caries, probably 90+% of this disease occurs in the low-income population. And it's virtually all cared for by Medicaid providers. As you well know, the only Medicaid providers are generally community health clinics. And in Rochester, that's Eastman Dental Center, provides about 80% of the care for low-income families. And there is here's another quite remarkable statistic. When a parent is referred to a pediatric dentist who provides care in an operating room, because there are very few pediatric dentists in Rochester who even provide care in the operating room environment. Most do not. Those that do have a backlog of ranging anywhere from 3 to 6 months. Now, if you look at these pictures I just showed you, you can appreciate many of these children should be seen immediately, tomorrow, next week, not next month or the month after or the month after that. But there just simply are no providers. And even if there were providers, the resources aren't there in the operating room environment for them to get table time to treat these children. So the community providers are at a big disadvantage. They bear a huge burden. They have a lot of responsibility for caring for these children, both in primary care as well as tertiary care. Private care providers share the burden in part because of those primary care providers who do see Medicaid patients. They are very depressed by the fact that they're presented with this horrible disease process about which they feel helpless to do a heck of a lot about, and they have difficulty referring to providers who can deliver the care but yet still have a big waiting list. So there's a burden on the private providers. There are an insufficient number of private practitioners, in particular generalists and pediatric dentists, who can provide the level of care necessary for treating this very severe form of this disease. I mentioned here preschool programs also bear a terrific burden, because when the children are brought to these daycare centers, I just have to give you a little bit of background here about why I'm including these preschool programs. In Rochester, the pediatrics department in the School of Medicine and Dentistry initiated a telemedicine program called Telehealth, and they started it in the inner city daycare centers. It's now expanding more broadly out into the community, and we hope to just follow right in their footsteps. But it started in the preschool programs in the inner city. These are primarily Medicaid-eligible children who are brought to these centers. And one of the problems the centers have, and the parents by extension have, is that when the children came to the daycare centers, and if they were ill, then the daycare center had to call the parents had to come pick the kid up, take the kid to see a pediatrician or to the emergency room or to wherever. With the advent of telemedicine and the Healthy Access program, the health aides in the child care center could image the tonsils, the throat, the ears, the nose, and interact in real time with a pediatrician at the medical center, and treatment could be prescribed right then and there, sparing the parents from having to come and pick up the child or the child having to leave the daycare center in many cases. So we were interacting with the peds about this and said, well, how many kids come with toothaches? And they said, well, we don't know. Nobody knows. But the daycare center operator said, heck, that's our biggest problem. These kids come with toothaches. And we said, holy moly. So we piggybacked on to the pediatrics program and started imaging children's teeth. And that's where our data now are coming from. We have a major project going on to not only identify or to determine the prevalence of early childhood caries, but to try and then find dental homes for these children as well. And I'll talk more about that in a little bit. But the preschool programs are impacted by this disease because it's one of the most prevalent problems the daycare centers encounter, and typically they would have to, and unfortunately for dentistry, if the problem is acute, interacting with real time with us means nothing, because as you all know, we have to do something pretty much physically. We cannot just simply prescribe something, perhaps Tylenol or ibuprofen or something, but we can't do a whole lot. The peds, on the other hand, can prescribe antibiotics and other materials, and life goes on. But for the dental problem, the child has to be physically treated at some level. But nevertheless, the preschool programs bear the burden because the children with toothaches either have to leave the program or they have to be taken care of or cared for in some form or another. Employers are impacted because when parents have to leave their work to go pick up a child who's ill or has a toothache, whether preschool or elementary school, then the employer is impacted by this disease as well. And Jay probably can give a better data than I can, but I seem to recall that the cost to employers for lost time due to dental problems is a fairly astronomical number. Does anybody know what the number, $47 billion or something, million dollars? It's a huge, huge number in terms of number of hours lost for dental problems. And in the case of early childhood caries, when parents have to leave work to go get the child and then perhaps try to get the child into a dentist, typically a community dentist, I can tell you the waiting time for even emergencies at a place like Eastman, which is inundated every day with up to 75, 80, 90 emergency cases, might be 3, 4, 5, 6 hours just to see someone. And then, of course, the public-private insurers. In particular, I'm not going to dwell much on the private insurers because most of the people who are affected, the families that are affected by this particular variant of dental caries, do not have private insurance, but most of them do have Medicaid. And Jay talked this morning about the national average for Medicaid utilization as being 38%. I don't know where that number comes from, but we don't get there in Rochester, and I think we have some of the best access to care in Rochester that you will find any place in the state or perhaps in the country. We have community health clinics located on the medical center campus, in the downtown Rochester, in the schools, and have 4 mobile units. And still, our utilization rate is only about 25, 26%. So a question I always ask is, what's happening to the other 75%? They're not going anywhere else in Rochester because we are the 800-pound gorilla. We provide 80% of the care for Medicaid-eligible children. So where are they going? The fact of the matter is they're not going anywhere. So still a key question might be for future researchers is to try to determine what influences these health behaviors towards oral health care, particularly among impoverished populations. But it impacts the public insurance, Medicaid, because it's the greatest single cost driver for Medicaid oral health care. I asked Jay, I said, how much do we spend, how much does state Medicaid spend on Medicaid cases? His figure of 4,000 OR cases per year is a huge underestimate. We do over 1,000 a year in Rochester alone. So I think the data that they have is quite inadequate and underreports how much is used. The average cost to treat a kid under OR, under GA in an OR, it ranges, depending on where you are in the state, between $1,500 and $5,000 per case. And Jay has estimated that it probably, Medicaid costs are probably in the range of $20 million a year across the state. They can't for sure because of the way it's charged out. It's charged out because when it goes in the hospital, the hospital bill is separate from the dental bill, and the dental bill actually comprises a fairly small amount, but you have to include the total cost in thinking about the cost to Medicaid. And so this is a big driver of Medicaid costs. And one of the systems changes that the State Health Department would like to bring about is Jay's idea of caries free by 3. And that's absolutely where it is. We would concur with that from a real world standpoint 100%. If we can get kids through that age 3 caries free, we've made a big step, taken a big step forward. So I don't need to dwell on this because I think Jay covered it, 25%, 80%, 20%, 80%. Poor children have 4 times the prevalence of caries. And more importantly, they have 2.5 times more treatment care need. I think Jay covered that very nicely. But here's the latest report from the Centers for Disease Control, 2009. This is the 2010 target. You can see that the U.S. is missing this target substantially. These are for children now ages 2 to 4. And Jay indicated this morning that this group, uniquely from other groups, is actually increasing in caries. While others are remaining level or continuing to slightly decline, it is apparently going up in the preschool children. There's a lot of speculation at the moment as to whether this increase is real, and if it is real, what's driving it? Is it the switch to bottled water? Is it the other factors, dietary factors, feeding behaviors? We certainly do not know. But one can see that from 1988 to 94, we see the one level, and then the latest information, the 2004 to 2008 data are currently being tabulated, so we should have that probably next year. We'll get some better sense of whether this is real or not. But there's another interesting sidebar to what's happening here. If we go back in history, females have always exhibited more caries than males, and typically at an earlier age. And this has always been attributed to the fact that females erupt teeth, including their permanent teeth, earlier than males. Therefore, their teeth are at risk for a longer period of time, and therefore they get caries earlier, and they maintain that caries lead throughout life. But this is switched. Suddenly, males have more caries, and fairly substantially more caries, than females. We don't understand this. We don't understand this increase. But at the community level, we certainly see it. So that's sort of a short version of the burden of this very early caries process in young children at the community level. And then when we look at the family level, we have to look at, of course, the affected child or children bear the direct burden of this disease. Some things we don't know that are intriguing is why one child in, say, a family of 4 children, one child is affected and 3 children are not affected. And sometimes the oldest child is affected, but not the youngest child, with the 2 middle children being somewhat affected. So there are some familial issues going on here that we clearly don't understand within the family group that causes one child to be more at risk than another child. The parents and caregivers, obviously, it should also be fairly apparent that this is a terrific burden on the parents and the caregivers for the child. Steve talked this morning about prenatal care for periodontal disease. There's also compelling evidence to suggest, to show an association between low birth weight and premature babies for women with dental caries, with active dental caries. So maybe it's not quite obvious yet, but there is a strong suspicion that oral health plays an important role in the health of the offspring. We have good data showing that the vertical transmission of the primary cariogenic organism, mutans streptococci, to children comes from the biological mother or the primary caregiver, and that it's a vertical transmission from mother to child. A mother with open cavities is going to transmit a higher bacterial load to that child, predisposing that child to greater risk than a child whose mother is completely healthy and without caries. So getting a mother healthy, or having good oral health, can be very important. And oftentimes this is not so. But the parents bear a terrific burden other than this from the reasons I discussed with related to society in terms of the care, the extra care that has to be provided for the child's oral health. I think too, I had another point here. Well, it'll come back. Oh, I know what it was, because I saw somebody sleeping back here. There are some interesting data about, and it's just interesting. This is not something you can go take to the bank or to the mattress, as the case may be these days, but that women during pregnancy and after, or who suffer postpartum depression, have their children are at greater risk for these early childhood caries problems than others. Women who have problems sleeping also tend to have children at greater risk. And the anecdotal, because there's no hard data on this, but the anecdotal data suggests that mothers who are depressed, who don't sleep well or have problems, they are more prone to give a crying child a baby, a pacifier or a bottle pre-sweetened with a sucrose-containing beverage, therefore making the child at greater risk. However, it's not as simple as that. If it were that simple, we probably would have figured it out a long time ago. But we have not. We have not been able to figure it out entirely. Feeding behaviors are one risk factor, but not the only risk factor associated with the onset of early childhood caries. But clearly, the parents play a huge role and have a burden to play as well. Access to care and utilization. Now, perhaps in this part of the state, access to care is more of a problem than it is in Rochester. In Rochester, the problem is we just flip it on its end. We have plenty of access to care for low-income populations. Our problem is utilization. How do we reach the population that needs the care? How do we change their behavior? How do we change their attitude towards utilizing oral health care? We have two projects that have really been depressingly unsuccessful. A project to find a dental home for children modeled after the Medical Home for Children program. And while that has been fairly hugely successful, we have been relatively unsuccessful in bringing low-income families into finding a dental home for them. And not necessarily a community health clinic like ours, but anywhere in the community. Again, getting them to utilize that, the availability of that care. So access to care and utilization. A second, I should mention also, we have another project with the pediatrics department in that we have started training. I'll talk more about this in a little bit, but we've been training pediatricians to recognize the onset of early childhood caries and for them to refer children. Well, they enthusiastically embraced this whole concept, and so they just started referring lots and lots of families. The experience on the dental end, however, was only about 10% of these families followed through with the referral. They didn't come. They didn't come to us. They didn't go anywhere. So I said, I wonder if these are the same people that don't follow through with their medical referrals. The peds give medical referrals to cardiology, neurology, psychiatry, dermatology, ophthalmology. And I said, I wonder if they have trouble with them keeping these referral appointments. So we did a study, and they did not. 10% followed through on their dental referrals, 90% followed through on their medical referrals. So there's a huge disconnect here, and we haven't figured out yet, how do we change this behavior? We haven't figured it out. I've already discussed about the morbidity and mortality risk. Children sometimes suffer adverse outcomes from an operating room procedure, and occasionally a child dies. And last year we had a child die at the University of Rochester. Turns out the child had underlying medical condition, was severely retarded, and there was nothing that was a direct result of anything that was done by anesthesia or by dental. The child died. Nevertheless, it was quite disturbing to everyone and just pointed up rather graphically the significance of the mortality risk associated with the treatment of this disease, any disease for that matter, in children under a general anesthetic. So I put these two slides up. I usually use these primarily for continuing education and for lay people, but I thought these were very appropriate for this presentation because it's not this simple. We always more or less just equated the feeding behavior and the outcome as a cause and effect relationship, but it's much more complex than that. It is more than the feeding behavior. What more, we don't know. And there are a lot of investigators in the U.S. and other parts of the world who are trying to sort that out. There are the NIH, the National Institute for Dental and Craniofacial Research have recently awarded two very huge grants to the University of Washington at Seattle and the University of California at San Francisco to try to develop not only primary preventive protocols for early childhood caries, but to try to understand more about the antecedents to the actual onset of this disease. So now let's begin to talk a little bit about the cost. I think I've actually included some of the things I'm going to say here in the burden, but insurers, in particular Medicaid cost for oral health care is going up. The care for early childhood caries consumes a rather disproportionate amount of Medicaid funding for dental care. Hospitals bear a lot of the cost because not only is there just the cost of treating the child under a general anesthetic in an operating room. Oftentimes, some part of the cost is borne by the hospital as uncompensated care for this disease. The dental schools in New York State, in fact, provide the largest safety net for uncompensated care of Medicaid-eligible families in the state. I've long since forgotten the exact figures, but it's well in excess of $20 million a year of care provided for uninsured or underinsured patients by the dental schools and by community health centers. Community providers certainly do provide more services than they are compensated for. So there's a cost to the community providers. The private providers oftentimes very generously, those who agree to provide care for this very difficult population, whether pediatric dentist or general dentist, often do so at no charge or at no cost, in part because they're good citizens and good health professionals, and in part because of the perceived bureaucracy and red tape associated with being paid for seeing patients that they don't ordinarily see, and they're not comfortable and they don't do it. But nevertheless, there is a cost involved there. And we've talked about employers bearing a burden. Employers obviously also share the cost, as well as the employees share the cost of this disease because of time lost from work, lost productivity, and lost income. The family not only bears the burden of having the disease, the family bears the burden of, I mentioned, taking off work, lost income. Transportation. Many low-income families do not have reliable, adequate, available transportation to get them to a community health center in a timely manner. One of the exercises our social work services does for new residents in pediatric dentistry is to put them on a city bus. and direct them to go out into the city by bus to the furthest point, transfer, and come back to the medical center. It's a half-a-day affair because by the time they get on the bus, they get downtown, they transfer, they get out to a neighborhood bus, they wait on a neighborhood bus, come back downtown, transfer, come back to the medical center. And these students have a new appreciation for why their patients are often late or don't come at all, because transportation costs and problems. Preschool school costs, again, children not in school or the school health personnel have to provide care for children with a dental problem. And I mentioned poor treatment outcome. The treatment outcome is actually quite unacceptable, and so we have focused our work in Rochester now on improving treatment outcomes for these cases. I indicated to you that about 50% of these cases relapse after about 6 months. That means they have to be treated over again. Again, more cost to everyone, to the insurers as well as to the family, to the businesses, the whole 9 yards. The whole thing is repeated again. So we are trying to focus work, and our little niche is led by Dr. Bob Berkowitz, who's the chair of the Pediatric Dentistry Department, to identify protocols, tertiary preventive protocols for children coming out of an OR, let me rephrase it, children who have been treated in the operating room environment, to develop new preventive protocols to reduce or minimize the recurrence of this disease. This is starting. I mean, I can't tell you what the outcome is. We hope the outcome will be favorable, but we don't know. Part of the reason I hedge my bets is because one of another associated problem is that parents who bring their kids have been identified and referred for this very severe form of caries. They're treated in the operating room. One would think that these parents are going to be much more careful about bringing their children back for recalls. But no, in addition to the relapse, greater than 50% are never followed up. They don't return for their recall visits. So how do we reach these folks to get them to come back? If they don't come back, then they're not going to be able to avail themselves of the preventive protocols that are in place, hopefully to prevent the disease process. And then lastly, as Jay said this morning, clearly, caries begets caries. Children with early childhood caries or severe early childhood caries are at substantially greater risk to caries in their permanent dentition. So they're going to be burdened both with the disease and with the cost of the disease, going forward in time throughout life, unless this process is somewhere interrupted. So here are just a few words about this. I don't. Do they get handouts of this, Tom? So if anyone has interest in these publications, please feel free to contact Tom. He'll get me. I'll be happy to provide this for you. But here, 40%, only 40% return. 72% have new caries. This is of the 40% who returned. We don't know anything about the 60% who did not return. We saw that 45%, this is relapsed by 12 months. And in another study, 31% returned in 6 months and 38% had new caries. So some variation, but not a great deal of variation. So how can we begin to reduce the burden to society? I loved Jay's slide this morning with the little diagram with health outcomes, and he showed system changes, family changes, community changes, and so on, because we are operating in each one of these environments. Clearly at the public health, the national and the state and the local level, we can certainly do more than we have been doing. What that more is, I don't think we know exactly what more is. We know we need to be doing something, but I think by and large we are largely spinning our wheels until some new information comes out as to what is working and what is not working. Clearly, what has been done up to now has not worked very well. Social services play a huge role. The social worker in our community health clinics is a very busy person who attempts to wade through all of the barriers that inhibit utilization of oral health care services. That runs the gamut from providing transportation to identifying ways in which treatment can be paid for, and working with employers. And so social services plays a big role in helping to bring about change. Medical dental education. We have a project going on to train pediatricians to identify children at the earliest stage of the disease. All we tell them to do is lift the lip. And if you see any white that doesn't look right on a tooth, get that kid referred. But you know, it doesn't stick. And I liked Steve's little joke this morning about the relationship between the dentist and the gynecologist. But pediatricians are not much different. Just like us in so many ways, having not been trained to, although that's not true today, it's changing very rapidly, but we focus so exclusively on the teeth that we missed other things. And so the pediatrician looks for the tonsils, looks in the ears, and goes right by the teeth. And here we catch them when they're pediatric residents, and we need to be catching them when they are freshman medical students, and this training process and integration process needs to carry on through medical school. And dental school also is still really doing not a very good job, frankly, in teaching the underlying biological and social risk factors for dental caries. I mean, we see that. I teach 2 courses, and we teach a course in cariology also, and sometimes I have to wonder where some of these kids went to school. I mean, and we're supposed to be getting the good ones, so but maybe it's just us. But clearly we need to have more emphasis on risk assessment, and Jay indicated that the paradigm is starting to shift away from these rigid 6-month, 12-month recalls, whether you need it or not, one size fits all, to risk-based recalls. We're planning to do a study to determine if in fact does that work? Does risk-based recalls work? Is there any merit to changing from 6-month recalls to risk-based recalls? So we're going to try to identify if patients who are seen on a risk-adjusted basis are as well off or better off than patients who are seen religiously every 6 months for screening, prophylaxis, and fluoride and whatnot. Clearly, low-risk individuals don't need it, but I think we are often very frightened of what might happen if we don't see that person, in spite of data to the contrary. So we have to work very hard in this area. Prenatal and perinatal providers, I don't need to talk about that. I think Steve talked very nicely about prenatal care for pregnant women. Perinatal providers, we have Tom has a good perinatal program down here. We have one. We're beginning to reach the WIC people, the midwives, dental hygienists, dental assistants, many people who are in position to influence oral health behaviors. Oral health providers can also, as both Steve and Jay indicated this morning, play a role here in terms of expanding their practice to include some low-income patients. And public-private insurers, clearly, pardon me, both the private insurers as well as Medicaid are looking for ways to cut costs. As Jay pointed out this morning, the costs are just going up astronomically, and we, the people, all of us, are paying for that. So ways are being sought to reduce the burden here, but it all revolves around better risk assessment, better preventive protocols, better utilization, better oral health behaviors, and it's sort of like President Obama and addressing the problems attendant to the country. He's not blessed with the good fortune to have to address just health care or just employment or just real estate or just war. He's working on every front, and we are also. We can't just focus on one aspect of reducing the burden. And I think, how much time do I have? 5 minutes? Okay, I can finish up in 5 minutes. So I think that in terms of reducing the burden with the family, we can do those things that we know will be beneficial in terms of attempting, at least on the basis of what we know, to influence maternal-paternal behavior, children, school health programs, getting children into care, doing the best we can. The extended family plays a role here as well. Many poor children, impoverished children, are cared for by an extended family or in daycare, and these individuals so play a role as well. Reaching these, we have programs in daycare centers and with family units to try and improve that. And then finding a medical dental home. So far we have not been very successful in that approach, but maybe we don't know enough to know how to do it properly. So we want to expand the safety net, and this is where it's going. This is what's happening now, and this is going to be happening in New York next year, is that children usually see pediatricians or well baby health professionals before they see a dentist. And here's before 2 years of age, 362 to practically 0. 2 to 5, 193 to 37. It doesn't begin to catch up until the teenage years that children are seeing dentists with about the same frequency as a physician. So we're taking advantage of that. The North Carolina Fluoride Varnish Project, some of you may be familiar with this project, but North Carolina actually amended their Medicaid eligibility law to enable physician assistants in pediatricians' offices to apply fluoride varnish to the teeth of young children and to be paid for it. And so this has had ramifications far beyond just simply providing fluoride varnish periodically to the teeth of these children. These lay health aides have also influenced oral health behaviors and have increased the number of families who are seeking out dental care as a consequence of this early involvement by the pediatricians. So this was quite an interesting project, targeted low-income children. Medicaid provides reimbursement and relies on non-dental personnel. And as I say, a similar project is going to be underway, which is being undertaken by the University of Washington at Seattle, and Rochester will be one of the satellites for that study. So I should just close up not only by saying thank you very much. As I say, it's a tough act to follow. Two dynamic speakers this morning, especially after lunch, so I very much appreciate your staying awake and your attention. And if you have any questions, we'll be around after the presentation. Thank you so much.